equity, health and rights, inclusivity in medical practice. We at SCORA have five major focus areas, which include CSA, comprehensive sexuality education, MASA, maternal health and access to safe abortion, GBV, gender-based violence, SOGI, sexual orientation and gender identity, HAS, HIV, AIDS and other STIs. Through all these initiatives, the one initiative which we want to convey through this webinar is the sexual orientation and gender initiative. Through this initiative, we are committed to building an inclusive, equitable, and a stigma-free healthcare space. And today's session is a step in that direction. As future healthcare professions, understanding the lived experience and healthcare challenges faced by the LGBT community, by interacting with a professional speaker, Dr. Aqsa ma'am, we would like to welcome you, ma'am. Thank you for joining us. I have introduced myself first. Hello, everyone. I am Mahiba Jadeja. I'm currently serving as the National Officer on Sexual and Reproductive Health and Rights, including HIV and AIDS, with my co-Nora.
Hello, I'm Jia Mehta. My preferred pronouns are she and her. I'm serving as a National Officer on Sexual and Reproductive Health and Rights, including HIV.
Thank you so much, Jia and Mahi. So before we start, I will introduce our speaker with us. So today we have Dr. Aqsa Shaikh with us, who is an out and proud transgender woman. She is one of India's first transgender doctor, and she is a professor of community medicine at Hamdard Institute of Medical Sciences and Research at Jamia Hamdard, Delhi, and patient safety officer of HAHC Hospital. Aqsa ma'am is an academician and researcher. She undertakes research and advocacy for inclusion of transgender and disability communities in the healthcare sector. Aqsa ma'am is a vocal advocate for right-based gender justice for transgender persons. She is a leading voice for health access for transgender people. She speaks, writes, and advocates for trans rights in India and globally. She is a TEDx speaker, a poet, and a practitioner of theater. Ma'am is a member of the National Task Force for Prevention of Student Suicides in Higher Education Institution. It is a privilege for us to have ma'am with us today and, give us the information, give us the ground reality about what it is, to practice with pride in healthcare and, inspire us and, maybe we can be motivated enough to become advocate and be vocal just like how she is. Thank you, ma'am, for joining us and welcome again. Ma'am, the floor is yours.
Thanks, Partho, and good evening, everyone. It's really my pleasure to be joining for the second time for a conversation of this sort with MSCI and SCORA, and to have the conversation. And I think this is great because these conversations need to be ongoing and to be widely disseminated and available. And I say this as someone who has been a medical student and is now in the medical college as a professor. In fact, I often say this, that for 25 years I have been in a medical college. I started my medical education in the year 2000, and now I am a professor of community medicine. So the past quarter of a century to spend in the medical system and to understand the ins and outs of it. That experience is something that has been really helpful. Because I remember when, as a 17-year-old student, I entered the medical college. I am born and brought up in Mumbai, so I studied from St. GS Medical College in KM Hospital. And, that's, of course, like a dream come true for a lot of people to get admission in a good medical college, since I'm the first doctor in my entire Khandan. So that happens, right? But then you enter and you find that the world over there is quite binary, especially for someone who is struggling to understand their sexuality and gender identity, or someone who is facing, mental health risk factors. And I remember one incident which I would like to narrate is That happened in the physiology. I at that point of time didn't know that I was a trans person. I knew who I was, but I didn't have a label for it. What do you call this state of being? Um, but then this happened in the physiology practical that you have to often, volunteer to become like patients for other people to practice examinations in the form of palpation and so on. And at that time, since I was a male person visibly, I also had to volunteer, remove my shirt, lie down on the table as around 20 people watched me, touched me. And I remember no one asked for my consent, or no one saw if I am uncomfortable or not. And as someone who identified as a woman at that point of time, I knew that I am a woman. That was extremely dysphoria inducing for me. But I couldn't say anything. I couldn't raise my voice because then you become more a victim of harassment. Because you don't want to attract a lot of attention of other people towards you. But then that made me realize how our medical education system assumes that every person who looks like a male is a male. Or even, I say this that even if I was a man at that point of time, still no one asked me if I'm comfortable being touched by other people, or, no one to consent to do that examination. It was all assumed that I'm comfortable. Um, I hope things have changed, and we have done some reforms in some colleges where we are using mannequins to do the examination, or we have a protocol on how to take consent even for volunteer medical examination. Sometimes, you have college staff who is made to do these jobs. So how do you have the protocols? Another incident which happened was, ours was a very busy government medical college in which patients often are treated on the floor, and naturally there are space constraints, including in the OTs and in the changing rooms of the OTs. And there used to be male changing room and female changing room, and the male changing room actually didn't have cubicles. It was like a hall, and everyone changed in front of everyone, which is a common practice, maybe amongst people there at that point of time. But then I, as someone who identified as a woman, found it very dysphoria inducing, uncomfortable to change in front of other people. And I remember I would wait for all my batchmates to change and go, and when I was alone and with some privacy only, then I would change. But then again, as an 18, 19-year-old person, you can't speak about these things because it's like this is how the system works, this is how things happen, right? um, and a lot of small things in our lives as medical students then get dictated by these so-called systems which have been designed at a certain time for a certain set of people, but they are not keeping pace with time. Like, for example, hostels, of course, that's a dreaded story for a lot of students, including for trans or queer students. And as a student who identified as a woman but was on paper a male, at that point of time, I couldn't get girls' hostel and I couldn't stay in boys' hostel, which means that, my career choices were also then defined by going for a field in which I don't have to change my city or I don't have to stay in a hostel. And therefore, I took community medicine because, you could manage it without any night duties or without staying in a hostel, etc. But then there are a lot of these stories that, we keep hearing of other trans students. And I still say I'm very privileged because, and I realized my privilege when COVID happened, and when the vaccine was introduced, and I became the COVID vaccination center's nodal officer. And I realized that I'm the only Indian trans person to head a COVID vaccination center. And that is how I became, popular, because a lot of news articles followed that story. But then, it also made us realize that it was sad, because why should, in a country of 130 crore people with nearly crores of trans people, someone shouldn't be having that position? And, we count the number of transgender doctors in our country. I'm one of the first. I'm not the first one, but one of the first. There have been a couple more before me. But then even today, in 2025, we have hardly 30 transgender doctors. And unfortunately, even most of them are not out. And that's a sad story, ki why in the medical system, trans people are not able to come. And I say this because there are probably more trans engineers, lawyers, teachers, or people in other professions as compared to medicine. And the medical system has, certain aspects of it because of which it becomes very difficult for anyone, whether you're a woman, whether you're a person with disability, whether you belong to any other minority. The system is not that flexible. And now that I'm working for, the students who die by suicide, or students who have suicidal ideation, or who attempt suicide, this is something that I'm realizing more and more, that there is a lot of silent stories, around. You think that someone is doing good. They are in IIT, they are in AIMS, they have a very good profession. And then after a few days, you come to know that they are no more. And therefore, it's very important to document these stories, to talk about these stories, to look at what could we have done as a society, as fellow batchmates, as faculty members, to change the system. Because see, the cost that we are paying is in terms of life, and nothing. As medicos, we don't need this to be re-emphasized that life is the most precious thing. And people are dying because of our apathy, because of these systems that we have put in place. And, apart from the various causes of medical suicides dying by it, one of the causes is, them being coming from a minority, and then the minority stress which can happen. And as a minority, of course, today we are talking about gender and queerness, but it can be also linguistic minority in certain states which have strong native identity and pride. But going back to my journey in the medical college, that is something um, I realized at that point of time ki how difficult MBBS can be, as a trans people, and why there are no trans people out there as doctors. I would say I barely passed MBBS because of the severe depression that I had to go through at the time of my final year. Um, but then that happened, MD happened, and I became a faculty in the medical college, and naturally with that comes a lot of privilege. But then there were other troubles that come with becoming more open, because now you have to go and take lecture for 150 people, and that's the batch strength in my college. And the college, which of course has is a Muslim minority institute, so of course there are certain cultural aspects attached to it. And I transitioned when I was an assistant professor. So to transition, and that lasted for a period of 2 years, from hormone replacement therapy and me dressing up as how I dress now. That all happened in front of my medical students, and I received some immense amount of support. When I was getting operated, my family was not there, but my students were around. And at the same time, a lot of backlash too from the medical students and other doctors. And that made me realize that, you can't really win biases or discrimination only by knowledge. You also need to work on, people's attitudes. And most importantly, for them to know someone of like that, to be a friend of someone who is trans and queer. Um, I often ask a lot of people when I do workshops, do you have a transgender friend? Or do you have a queer friend? Or do you have a friend who is a Dalit? Or do you have a friend who is a person with disability, a blind friend? Because unless we make those connections, that empathy development cannot happen. Now, coming back to the COVID times, some interesting snippets I'm sharing just to build upon, what we want to talk next is I had COVID infection thrice, and for the first time, I was in isolation, of course, for 10 days. And during that time, in spite of being in my own hospital and being treated by the doctor who was my student and who knew about me as, being a trans person or and undergoing transition in front of them being a witness to it, um, I was treated as a cisgender woman medically. Now, that, of course, is something which we would want on another day, but when it comes to medicine, you don't want to treat someone as a cisgender when they're transgender. So, an X-ray happened, and I was told that there are shadows in my lung, and I need to start on antibiotics, etc., and so on and so forth. But then there was a smart radiology head who knew about my medical history and who said, "Ki maybe these shadows are probably shadows of the breast implants, and this is not pneumonia." And we did it again in a different position, and we found that it was actually the shadow of the breast implants and not pneumonia. And that made me realize that, the hard, as I say, the hard aspects or the tangible aspects of medicine and the intangible aspects of medicine both need work. The medical knowledge also needs to take into consideration that some of our patients will be trans people and they have certain medical needs. Like, for example, I say, what is the normal value of hemoglobin for males and females? And people say, yeah, the cutoff is 13 for males and 12 for females and 11 for pregnant female. And ask, what is the cutoff for trans people? And we don't have an answer because we don't even know what is the normal hemoglobin for a trans woman or a trans man. Should I treat it as a woman? Should I treat it as a man? Or should I look into the aspects of whether they are menstruating, not menstruating? And this is just one example. It also then goes into other normal laboratory values. It also goes into the other normal values and physiological aspects. It goes into how, we perform cancer screening guidelines. And I often say this that, breast cancer can happen to men, women, trans people, anyone. But we don't have guidelines for men. We don't have guidelines for trans women who have breasts on how to screen them for breast cancer. And that means that if you're not screening, it's a matter of life and death. Same happens with cervical cancer. And therefore, we need to work on the hardcore aspects of medicine and ensuring that it caters to trans people who are transitioning, not transitioning, have transitioned surgically, hormonally, and so on. Another example, which is currently what has happened, is I was diagnosed with migraine because I was having headache for a lot of time, and uh, people consider that a middle-aged woman having headache, migraine, very common diagnosis if you've ruled out a lot of other causes. But then it was only when I had a syncopal attack and got an MR venogram done that they realized that I have a dural venous sinus thrombus, thanks to the estrogen that I was taking, or maybe post-COVID. And but it would not have been diagnosed had they not known that I am on estrogen. And no one asks me in general if I am on HRT because they assume that I am a cisgender woman. So these are certain, hard aspects. On the other hand, sometimes you may have the full knowledge, but still you can be a very discriminatory, stigmatizing doctor. And that is something also very harmful. So we need to work on both aspects. So we're doing certain work with NMC and talking about including certain competencies that MBBS students should learn so that they can cater to trans queer patients. And also simultaneously including it in the EdCom aspect so that the attitude, ethics, communication, which is there, those aspects can also cater to the trans and queer needs. And fortunately, we don't have to, add more hours or more lectures or more classes for doing that. In the existing ones, also it can be done. So I give a very common example that in EdCom, you have case studies, that, okay, there's a surgical patient, you need to take consent and so on and so forth. Now, what if that patient is a trans person? What if that patient is a trans person who does not have a biological family but chosen family with them, who do not have legal rights of taking decisions or giving surrogate consent? just changing the gender of your case study can make a lot of difference. In some of the colleges now, when we talk about the family study in community medicine, etc., we typically go to cisgender families. I often ask this question: why don't you take people to where the transgender people live? They also live around you, and they are also in need of being studied. So some of the colleges have now started, doing that they at least some families are taken from there. And these small initiatives in the existing system and of education can bring in, can fulfill a lot of need of education for existing medicos, whether in undergraduate studies or postgraduate studies. So yeah, I think, just wanted to share some of these stories so that you can ask more questions and get into a more conversation mode, more engaging mode, because these dialogues are important. So yeah, there were some opening remarks. Over to you, Path.
Thank you so much, ma'am, for sharing your journey with us, and talking about all the difficulties that you faced, and how it is different for everyone depending on their identity and where they come from. So we for today we have prepared a few questions, where we could to dive in and see how we as medical students can exactly be part of the inclusive workforce from when we are actually there in the hospital, and be more inclusive towards the communities. So I will share my screen now. Just is my screen visible? Could someone confirm?
Yes, it's visible.
Okay. Ma'am, so the first question we have for you is, the NMC recently mandated inclusion of LGBTQI plus health in the MBBS curriculum. What are the key changes which we as medical students should be most aware of?
Yeah. I mean, this is an interesting question about the role of National Medical Commission um, in bringing about LGBTQI health in the MBBS curriculum. Um, and there is a story of a U-turn that happened over there. So NMC, after a lot of pressure, etc., came up with a set of LGBTQIA competencies, especially in the subject of forensic medicine and psychiatry. However, when the new curriculum was given in the month of September 2024, then these were rolled back. I don't know how that happened, but someone realized that we don't need these competencies or something of that sort. And then people had to go to court, and the court had to really reprimand NMC that is there no one reading your guidelines, that you had them and then you removed them, and then now people have to come to court for them to come back into the curriculum. But fortunately, those guidelines did come back. But what did not come back, and I want to say this is also because I work on the disability rights movement, is the guidelines on disability. So just like we have a Transgender Persons Act, we also have a Rights of Persons with Disabilities Act, and that says that in the medical education, doctors need to talk about disability etiquettes. And certain hours, 8 hours, were given for it, which were removed, and which, in spite of going to the court, NMC did not reinstate. So that just wanted to point out that NMC has a lot of work to do when it comes to LGBTQI or disability rights. But then some of the things that have been included, I think, is the weeding out of a lot of wrong stuff which was there, which was not in sync with the existing laws. You see, when I was a medical student at that time, transness was considered a disorder. It was called gender identity disorder. Homosexuality was considered, of course, a crime under IPC 377. It was considered a sexual perversion. That's what our forensic medicine books taught us. And it was also considered a mental illness that could be treated with some conversion therapy. And there are a lot of articles that got published about conversion therapy. But certain things changed later on. One was, of course, the decriminalization of homosexuality, which happened in our country in 2018. Then in 2014, that the Nalso judgment came, which talked about transgender people as a different gender. We know that in the ICD, gender identity disorder is being removed. And the Psychiatry Society of India, Indian Psychiatric Association, also talked about it not being, homosexuality and transness not being a mental illness, that conversion therapy does not work and doctors should not practice it. And then a lot of court cases happened. Madras High Court, Kerala High Court intervened, and they told NMC that, see, you need to change your curriculum because your curriculum is still saying it's a crime, that or these are sexual perversions. And then NMC brought certain changes. Similarly, adultery, which was removed as a crime from the Indian Penal Code, continued to be a crime in our medical textbooks. Or we still had the two-finger test, for checking the virginity and sexual assault. So certain things which were very bad, offensive, outdated, were removed, which was a welcome change. And this is something which is still happening because I know that still in some of the videos that I see of the people teaching in coaching classes, they still talk about a lot of this stuff, unfortunately wrong. And then certain competencies were also added in the field of forensic medicine and psychiatry, especially, which, talk about how to look at a victim of sexual assault and how to do that examination and how to also take consent. But then we believe that that is, a band-aid for a tumor. It's very superficial. It's not going to help because and it needs to start from physiology and not from the subjects we deal with pathology like psychiatry or forensic medicine, which deals with, of course, offenses. It needs to start at physiology. And I say ki why we do not have transgender cadavers. If we only see male cadavers and female cadavers, then because our trans body is not normal bodies. But I often ask, have you ever seen a disabled body as a cadaver? Unfortunately, no, because these are not considered to be, fit for as normal bodies to be examined by medical students. And that is where the concept of normalities needs to be challenged. Because if you don't understand that trans people also exist, or disabled people can also exist, then actually that concept will go on and there is a pathologization which happens because according to you, normality only means certain thing which I was taught in first year. So it needs to change holistically. And most importantly, the communication aspects of how to speak, how to talk, because, a lot of well-meaning doctors, also their medical students are there. They have a lot of respect for queer and trans people, but they don't know how to talk. So inadvertently, they may end up offending them, or because of the fear that they don't want to offend, they'll not speak only to them, and that also happens. And that is both the situations are bad because often we do not get a choice of choosing our patients, and they may also not have a choice for a medical person in the times of emergencies. And that is something, we often get to hear that, okay, there's a patient in casualty and they don't have a relative who will sign the form for them. So what do we do? Or a lot of other stuff which are still happening. So the NMC has done some work, but we need to build upon it. We did send them a set of competencies to add on. Unfortunately, they haven't taken that into consideration. But I feel, there is a curriculum which is on paper. And I think medical students know this much better than me. And then there's a curriculum which you learn in reality. And I think it's important to understand the practically learned curriculum can change irrespective of what NMC says. right? And therefore, the need of a parallel system where you can have workshops, seminars, or webinars like this, from where medical students can learn if it's not being taught in their classes through the existing curricula. And I think that's a very important pathway of learning and gaining the skills, because see, this is a skill set that is, I would say mandatory. If you get a patient and 5% of the times it's likely that you are going to get a chance to acquire patient, you need to know this if you want them to return to you, if you want to be a good, doctor, nurse, or any other healthcare provider. So this is a non-negotiable skill set that all of us need to learn. And I think NMC needs to do a lot of work here. And beyond NMC, I think up and beyond MBBS, things need to change in the postgraduate curricula also, especially those who deal with trans queer people, like in psychiatry, gynecology, even medicine for that matter, or endocrinology. These are certain things where all these things need to come more and more. So yes, a lot of work that needs to be done. And answering this last part of the question, I think medical students are very smart, and they know, okay, NMC gives certain things on paper, that is fine. But the entire world is actually your university, and you can learn from anyone. And trust me, I have learned more about trans and queer health from internet, from Instagram, in fact, even from LinkedIn, from listening to people, from attending webinars. And this is something which is not taught in medical colleges. So I would say that while NMC does its job slowly and takes ages for it, let's explore some alternative pathways.
Thank you so much, ma'am, for such a uh, comprehensive answer, and also telling how we as medical students can enhance our way of learning, even though NMC might be slow, by attending such webinars and everything. And uh, also, like, the curriculums need not be changed only for medical students per se, even for the professors and also the postgraduate students. Thank you for highlighting that very important point. So moving on to our next question, which I think you have already briefly covered, is, like, in your opinion, what do you think, do these policy changes that NMC have been doing are enough? If not, like, what are the additional steps do you think are necessary for the true curriculum reform to come, to see the true change that is happening on ground?
Yeah, as I covered this in my response to the last question, but just want to add about the medical legal aspect. As this, what are the medical legal aspects associated? And somewhere NMC needs to talk about these things but are not taught. One such example is, some of you might have heard about this trans couple from Kerala who had a baby. And that was quite a lot in news. And you also know that a lot of trans people go for freezing of their gametes for future use. But then these are things which are governed by law, whether we talk about surrogacy, whether we talk about assisted reproductive techniques, whether we talk about adoption, marriage, abortion, anything of that sort. And, these are the things which are governed by law. And that is often not taught to the doctors, which needs to be included in the curriculum. Like, for example, how many doctors or medical students know that surrogacy law is there? And now surrogacy is only allowed for married couples. If you're a single woman who has never married, you're not allowed surrogacy. You have to be either divorced or widowed to have surrogacy. And then comes the trans people, queer people, single gay men. Of course, they're also not allowed surrogacy. In fact, I have filed a petition in the Supreme Court regarding this law, and that it needs to be amended. Because why is it that a divorced woman can have surrogacy, but a single woman cannot have surrogacy? And that really speaks of the patriarchal principles behind such guidelines. How many people know that when it comes to assisted reproductive techniques, like a lot of trans people freeze their gametes or eggs, etc. Technically, that's possible and everything, but legally they are not allowed to do that. Legally, ART is only again in India for married couples and infertile couple. And this is something that we need to take into consideration.
Uh, yes, so sorry, ma'am.
No issues.
Leah, could you mute yourself?
So, talking about the laws which concern people, or for example, talking about medical termination of pregnancy, since we have transgender men who may need medical termination of pregnancy or who may need, treatment for menstrual disorders. But what does the law say about MTP being performed on men? And Supreme Court, changed the guidelines on the matter. So there are certain things that need to go in the curriculum also beyond medicine, including talking about law, talking about communication, talking about the cultural aspects of it. Um, because we say that we are making our graduates to become international medical graduates who can work in different countries, and we know that in a lot of countries a substantial number of doctors are from Indian origin who learn in our colleges and go and treat patients over there. And we need to have some kind of an idea about what is the culture in those countries, what are the laws in those countries, and to be aware of the global scenario, which is currently completely missing from our curricula. So those are certain things I would really wish that are added.
Uh, Thank you so much, ma'am, for highlighting another important parts about how such things in the curriculum and how to become international medical graduates, to become the competent one. It is very important for us to learn everything for a more holistic approach to healthcare in future. So moving forward, our next question to you is, uh, what are the some common unconscious biases as medical professionals might hold, while treating LGBTQI patients, and how can we, from the ground level, work to unlearn them so that those unconscious biases are not there when we are practicing on field?
Now, that's a very, very important question, something that we deal often. And I think, even as a trans queer person myself, I have also biases. And it's important to understand my biases and, to continuously keep working on them. No one can say that they're unbiased. We all have some or other implicit biases, and that's fine, and we need to work on them. And, I often, uh, just one example which I want to say is, people say it's a choice. When they meet trans and queer patients, they say, "Oh, everyone has a choice." Nowadays it's like choice based and everything. But what people don't realize that, especially when it comes to gender identity, sexual orientation, sexual characteristics, we don't have a choice. You never say this to a cisgender person that you had a choice to be a man or to act as a woman. No one really has a choice. And in terms of even your, sexual orientation, you don't have a choice. If you like people of certain sex, I mean, that is how you are inbuilt and how you're designed. Now, whether to act on it in terms of gender expression, that if I'm a trans person, whether I want to be dressed like this or not, yes, that is my choice. Or whether I want to go for a medical procedure or transition procedure, that is my choice. Or whether to have a partner of a certain sex or not is a choice. But the innate nature which is there is not a choice. And that is something that is, needs to be understood, because when I take workshops with a lot of medical faculty and professors, they always say, yeah, 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 we respect your choice. And I'm like, you don't say that to a diabetic person that you have a choice. Yeah. Because they didn't really choose to be a diabetic, though it's a lifestyle disease, which is not even the case with sexual orientation or gender. I think it's not a lifestyle. And that is something that needs to be, importantly done. Second is, the assumption sometimes in an attempt to overhelp to all the trans people to suggest transition. Because we assume, oh, if you're trans, then you must transition and you must transition completely, because today's world is about before after pictures. in every aspect, from weight loss to aesthetics and beauty. We like seeing those before after pictures, and especially even in trans people, we talk about this before and after, and how the medical science has become so good that someone can become a woman and you will never come to know that she is a trans woman, or someone can become a man and you will never come to know that they're a trans man. And in that aspect, I think a lot of dysphoria is given to the patients. And I want to give an example. When I was deciding on what transition related procedures I should undergo, I my plastic surgeon told me, he's like, why are you not getting a facial feminization surgery done? And I'm like, I'm happy with my face as it is, and I don't want to undergo any kind of cosmetic or plastic surgery to change how my face appears. And he said, no, your face looks masculine. You should go for forehead shortening. You should go for eyebrow raising. You should go for this chin reduction. You should go for rhinoplasty. And he suggested me at least 5 different types of surgeries so that I could look more feminine. And someone who was not very consciously, dysphoric about my face, I started thinking, do I really look masculine? Will that make me more happy if I undergo these 5 different sets of surgeries? And I often come across doctors, who would mention, ki, oh, you should go for this hormone or this, and sometimes in their over enthusiasm. So one important bias and maybe lack of knowledge that we need to understand is that not all trans people want to transition. Not all trans people want to take hormones or undergo surgeries or any kind of procedures or dress necessarily. That is something very, very personal choice that a person has. Another thing, bias which people have is that we change people. That if the people can be made into gay people, or if young children come in our influence, then they can be converted. And nowadays this trend is there, especially in US. As we have this conversation thanks to Trump administration, that children have to be protected, otherwise they'll become trans and all. And how our children needs to be protected, especially from trans women, from all these procedures. And we're doing immense damage to the health of the children by doing that. So no, one important thing to understand is you can't make anyone queer, or you can't de-queer them by doing any kind of convergent therapy. You'll be surprised, how common is convergent therapy in medical fraternity, even in this date when it is banned in India. And it's very commonly practiced by people with all sorts of medicines, which for which they charge, tens of thousands of rupees. So there are these small biases, which can happen sometimes unintentionally, thinking that they are going good for a person or trying to protect children or anything of that sort, but then they can be very harmful.
Thank you so much, ma'am. Like bringing about the idea of how we can go into our medical field with the implicit bias of having those biases pre-made, and like how we are told like it's a choice, and how we as medical students also like need have the choice to keep our biases aside and move forward with a more inclusive view, which is very important when it comes to treating people more holistically. So the next question that we have for you, ma'am, is we see that many healthcare settings are still, very binary and exclusionary. Like what immediate steps can we as, students and interns take to make our hospital wards or clinics a little bit more inclusive, a little bit more safer for the LGBTQI individuals?
I think, again, something very important and on which we are working is, um, the administrations in the colleges which decide a lot of stuff. And then there are the users. When I say users in the colleges, it is students, and in the hospital, it is the patients. A lot of inclusivity, whether it is in terms of queer rights or whether it is in terms of disability rights, has been driven by the students and the patients, not by the administration. I can give you numerous examples of how, the accessibility in the medical colleges or hospitals was challenged by patients and queer people, queer students. And then a ramp came up. And then, the extra time in examination came, or reservations were talked about, and so on and so forth. Similarly, when it comes to queer rights, we really don't have many high hopes from the administration. But I think when more queer patients come, or when more queer medical students come, then the system is going to change. Like for example, this is a very common thing which happens, that you have a trans patient coming to a hospital which only has a male ward and a female ward, and they are considering, oh, where to get this person admitted. Will the female patients be comfortable if a transgender woman is admitted in the female ward? Will they feel safe? Is the patient going to be safe if we admit her in the male wards? Can she use the washrooms, etc., especially considering the state of our hospitals? And this is something which is, a very common thing. And that question only happens when a queer patient comes, and therefore we encourage a lot of queer patients who can come to the hospitals to come to the hospitals, because once there's visibility, once there is a necessity, interventions will happen, they'll move. And that is why the presence of the trans queer people in healthcare providers as patients, as medicos, is very important. When I came out as a trans person in the medical education, I was actually in the PG at that point of time. I didn't know of a single trans medical student, right? Or a doctor for that matter. But today in our university, we have a few trans people, including in MBBS and post graduation. Queer, of course, a lot more number, and some of them are partially out also. And we also have some employees who are trans. And very recently, we, got 7 transgender people as GDA. Because these are the places, where you need to have trans people and, to change. Because I was like, this terminology that we use of ward boy or ward girl. And then I was asking this question, ki what, are you going to call someone who is a trans person, who is non-binary? And this thought will not come unless you have someone who comes and occupies this space. Similarly, a lot of changes happen because of medical students, and the role of queer clubs or student clubs or any forms of student association is immensely, I would say, powerful. In fact, we did a project with medical students across a lot of colleges, where we established what we call as queer ambassadors, who worked with the faculty members and administration to bring about one change during the time of the project. And some of them, have gone on and done much more than what we thought they will do, including just, asking that, see, the law is there, why are you not implementing? And going and talking to the dean and saying, the law says that since Aadhaar card has male, female, and trans, and in the OPD paper you are taking Aadhaar card, why we don't have a data of how many trans people came to our OPDs? Something as simple as that can make a huge difference. Or if the law says that we should have transgender toilets and disability toilets, why are they not there in our hospitals? So those small things also, if they can happen, or maybe calling a guest who is a trans person, and having an interaction, can make a huge amount of difference. So there's a huge role that medical students can play. And one example, of course, is this webinar, which is happening by MSCI and SCORA. And I always say this, that, the change can only be brought by the younger people. Because they are the ones who will be in the system for longer, and a lot of things are at stake for them. The people who are now old, they are not worried or concerned. And yeah, so I'm very hopeful with the younger people who are in the medical colleges currently.
Thank you, ma'am, for highlighting that we, the young people, we are going to take it forward. But also, you mentioned something. We need people to be present there, so that they can become examples. And it is very important for us to, tell our stories. But also, we have seen, once we speak up, it becomes very difficult. We do face a lot of backlash. So just taking forward from this thought, our next question to you is, uh, what was what kept you motivated through your journey despite the challenges, and what advice would you give the queer and marginalized students who are navigating medical school, and maybe they are open about it and facing backlash, or they are not even open about it and still uh, even though they want to be open about it, the environment is not conducive for them to be open about it. So how would you say, give certain words which could when motivate them, and um, to navigate medical school and healthcare in general?
That is when you ask me what was my motivation to start and then continue. So one thing is, I I I came to know about who I am at the age of 20 years. Before that, of course, I knew what are aspects of my personality, but I didn't have a name to give it. Or and then at the from 20 to 34 years, I knew who I was. Knew what I wanted to, but I couldn't do that. I started transitioning at the age of 34, which is relatively very late compared to the age that a lot of trans people do transition. And the motivation for that was my declining mental health, the dysphoria and not being able to be who I am and acting every day and becoming someone else. And, the pressures that come with it was literally killing me. And I was having suicidal ideation at that point of time. And thanks to transition and being who I am now, I'm a very happy person and content person at the moment. But something I that kept me motivated, and I was never an activist, and I didn't want to become an activist or a trans rights activist or anything. I wanted to live my own life, and that changed during COVID time when we saw the suffering of everyone around us, but then certain people who are already marginalized were suffering more. To listen to the stories of the people who are begging at the traffic signals, the trans people who are begging at the traffic signals, and during COVID and lockdown, they couldn't even beg at the traffic signals. Or a lot of them who are involved in sex work couldn't do sex work, or a lot of people, wouldn't even get ration because they don't have any kind of cards, or any kind of benefits. A lot of people couldn't get their ART medicines. Uh, and this suffering in general around, and especially with certain marginalized sections, was something that motivated me. Okay, now I have transitioned, I am privileged, I have a voice, I have a platform. Let me start talking about it and let me do something about it, because after a certain stage of life, you have what is the meaning of my life or purpose of my life, and that question kind of drives you. um, but beyond that, I would say a lot of strength that came in me is also by fighting for rights of other people who are not trans and queer. Like, for example, I have been talking a lot about disability rights or rights of people with mental illnesses or those who are in any sort of minority. Because minorities can only become strong when they club with other minorities, when they support each other, when they show solidarity to each other. And a lot of your biases can go. Then you realize how much privileged you are in certain aspects. Me being an able-bodied person, I know my privilege. Me being a person who comes from general category, know my privilege of not being from a person who is from scheduled caste or scheduled tribe. And we as medical students have biases about people from SC/ST or the use of reservation, where we question that, and there are things like that. Now, coming to the question of medical students coming out and how to do, I always have this one principle: is that safety first. If you think that the situation is not safe for you to come out to talk about it, to then further talk about rights of other people, you should not go for it. Wait for the right time, right place, right opportunity, right set of people to collaborate with you, and only then you should do it. Because let's be honest, there is violence which happens of all form: physical, sexual, emotional, and people also die due to transphobia and homophobia, which is there in our system. And therefore, your safety is something very, very important and paramount. And then go for the larger issues of advocacy and talking about the rights. But if you have the privilege, then don't stop, at yourself, and do speak for people who unfortunately are not able to speak for their own rights, and don't restrict it to only the things that you are fighting, but fight for all the marginalized sections of the society.
Yes, ma'am. Like another very important point that you mentioned is like we should see, what privilege we come from, and if we have the voice to stand up for everyone, like who is stand up for everyone who needs our voice, maybe a help from us. So yeah, that is something that we uh, really look forward in MSA and Scora, and to stand up for people, uh, you know, who don't have the voices, don't have that privilege, and like these are the small ways we help try to help to give them the voice that they need. So but also advocating for topics such as LGBTQI issues, faces a lot of backlashes. Our mental health do take a back step when it comes because of all the backlashes that we face. So just continuing with that thought, our next question and the last question to you is, ma'am, as someone who is involved in the National Task Force for Student Suicide Prevention, how do you see the intersection between mental health and queer experiences in education spaces? Like what support system are needed urgently in our medical, institutions and spaces?
Yeah, just for the context of a lot of people who may be wondering about it. So, what happened is in March this year, the Supreme Court of India, while it was hearing the cases of two student suicides from IIT Delhi, said that, looked into the matter and realized that these student suicides in higher educational institutes, in universities, is more than farmer suicides in India now. And the number of farmers, of course, is much more than the number of students, but the number of suicides happening in HEIs is much higher, especially from the premier institutes. And then it said we need to do something about it, and it set up a task force. And I'm one of the members of this task force, and we have a work to do in which we will find out what are the causes and solutions and submit it to the court. It's been 3 months of this journey, and a very rewarding experience so far, trying to understand why young people are killing themselves in spite of being in some very premier institutes like IITs, IIMs, AIMS, and so on. And as you mentioned, there's an intersection. Often when we talk about student suicide, we think, oh, their mental health must be bad, because there is stress. So we need to have more counselors, more mental health support, more psychiatrists, more psychologists, more therapy. But what we forget is what is the root cause of this mental stress? From why is it coming? And in a lot of cases that we are looking at so far, that mental stress comes from the system in which we are. Being queer or being trans person, I don't have a higher risk factor of anxiety or depression if I'm in a system which is supportive of me. But if that is not, then an identity of mine can become a source of distress because there is homophobia in the society around me. Similarly, being a woman is nothing, it's just your trait. But then when you are a woman in a society which is misogynist, which is patriarchal, which doesn't like women going to universities and studying, it can become a problem where sexual harassment is so rampant. And often, the existing mechanisms of redressal or ensuring that the HEIs are good places for students fail. And then the students feel, when they feel there's no hope, there's no help, what will I tell my parents? That often they have to take this step. And I want to talk about a news item that I just read today. It's in the newspapers also, if you see, is about this girl who was from Odisha. She was in a university. Uh, she alleged that she was sexually assaulted by a professor. She complained. The internal complaint committee gave a clean chit. She was on a strike. in front of the principal's office. No one listened to her. And then she poured petrol on herself and set herself on fire with 90% burns, unlikely to survive. And we'll add just one another number in student suicide. Was the problem with the mental health? No, the problem was sexual harassment of the girl students, which is happening, and the institutes failing into taking the preventive and corrective measures. And these are certain sad stories. And to talk Partho about this question, ki are queer people more susceptible, or queer students, in HEIs and their mental health? I remember one of our task force members, who is a wheelchair user, a person with disability, a disability rights activist, said that a lot of persons with disability are not able to do suicide because if you are a wheelchair user, you cannot hang yourself from the fan. And that was something, which struck me very much because, realize, or they're like, it is very difficult for them to stand up and jump off a railing. So this is the reality. And similarly, when it comes to queer people, for them to do suicide in an HEI, they have to first get an admission into a higher educational institute. Sadly, most of the queer trans people are not able to even complete school education because of the bullying which happens in the schools, and then to go to a college and then face, all the phobias and then die by suicide. Fortunate, unfortunate, I don't know, but that is the sad reality of the situation. And answering the last question and this one, a lot of this is preventable if we show solidarity with the victim. Often the victims who die by suicide have been giving out these small calls of help for a very long period of time to the people around them. But people are not listening, people are not helping. And when they feel, oh, I cannot be helped, it's only then that they want to take this step. I remember that when I came out, to my fellow medical students and batchmates, I had written chits to all of them saying, Ki, this is who I am, and I'm all that stuff, because I couldn't even talk about it face to face. Most of them read that chit, they kept it, and they never talked about it. Or someone said, okay, fine, you are there, but don't tell it to other people, or I can't discuss about this. Of course, those are a bit olden times, but then this is what happens. That often, we see that someone is suffering, and we don't try to help. And also because the families have told us, oh, don't get into the trouble, mind your own business. And I really don't like this phrase of minding your own business, because if all of us only, did mind our own business, then we can't really help anyone. And therefore, step forward, see who needs help in your surrounding, in around you, and provide whatever small help. And that help can be just listening, to that person. And I think today what you are doing, all of you, is just listening to me and having this conversation. And yeah, that's a great step ahead.
Thank you, ma'am, so much for highlighting everything uh so concisely, and you know even showing us the ground reality of how exactly things are, even though there are a lot of people who don't have the privilege of being in the education, in higher education, uh, but also, like, we being the trying to be the flag bearer of their voices. And hopefully this is one step that a lot of us who are here will take towards listening to our folks, listening to them, and looking for signs, if they need any help, to be there, to be the shoulder and start conversations. Thank you so much, ma'am. Now we'll open the floor for questions from our participants. If anyone has any question, please raise your hand, or you can put the question in the chat box and we can ask ma'am those questions.
I think we have one question in the chat group. I will read the question up. So we have this question from Avik. Avik asked if Avik can add on to the question, is the societal change needed before to the question when we asked about the curriculum of NMC?
Okay, I think Gia got stuck for some time. I'll just repeat the
Yeah,
question.
yeah. I read the question in the chat box, and this is an interesting um, question, because as someone who also deals with law, this question is often asked, that should the law change first or should the society change first? And this is like both need to work in parallel, because especially when speaking from the context of the law or technology in general, is that if they only change, but the society is not changing, the problem is not going to get solved. Like, for example, dowry, the dowry law is now nearly 50 years, but it is still happening because law is there, but society didn't change, or female feticide for that matter. Similarly, saying ki, oh, homosexuality is not going to be crime or nothing bad about it is not going to weed out the societal biases. But then you can't really wait for the society to become progressive, understanding for a lot of other things to happen. So those things have to move simultaneously. And most importantly, in a majoritarian system, where majority decides the laws and a lot of stuff, the when it comes to rights of the minorities, like sexual or gender minorities, it's important that they need to have a legal protection, irrespective of what the society and the majority feels about them, because the majority is often on the other side. So yeah, I would say both have to happen simultaneously.
We we also have the hand raised from Avik. Avik, can you unmute yourself and ask your doubt?
I believe Praha raised her hand before me.
Fastest finger first.
Yeah.
Thank-
If I may be a bit selfish in this question, how do you prevent apathy? Because one of the questions, like when I was asking around with my professors and interacting with them, one of the common refrains is that going to a deemed college was that your parents earn enough, just go out of India. That isn't really something I want to do, but it is something I've kind of become resigned to. So, how do you make people move? How do you change? How do you make people change their viewpoints? How do you make people change their rules?
One important life mantra a week is that you can't change people. And, and that's the answer to a lot of problems in our life, that we can't change people if they don't want to be changed. You can't help someone weed out their biases if they don't want to weed it out. And this is also true for our parents, for people we work with, for doctors, for teachers, etc. And that is where the law, helps people who are helpless in a situation. That even if, for example, I have, contempt against someone, if the law says you can't do it because there's a law which says that if I do this, then I may be arrested, that may be a deterrent for me to act in a certain way, even though I may not be doing that from heart. So yes, you can't really change a lot of people, but yes, sharing experiences, these stories and conversations and dialogues that we're having do have a impact in the long term. But yes, you can't change everyone, and that's where law can actually at least intervene and protect to some extent. And in India, we fortunately have a law which says that if you discriminate against a trans person in education, healthcare, occupation, housing, public offices, etc., it's punishable by 6 months of imprisonment. Yes, Praha, please go ahead.
Hello, ma'am. So glad to talk to you today.
Pleasure is mine.
So my question was that since you're a transsexual person and also a medical professional, I would love to ask if you have any communication tips that we could learn from uh, in hospital settings, the stuff that we could say which would make a person belonging to the LGBTQIA plus community feel better and talk more openly.
I also head the healthcare communication in my institute, and we do a lot of healthcare communications for our staff, right from the receptionist to the specialist. And my answer to your question is going to be more in general rather than only for queer people, is that we all have a choice of doing good communication. We all have a choice of being compassionate, of being kinder, and giving more time. A common refrain that people use is, oh, we don't have time to, talk politely, which is absolutely wrong. And, the same doctor who is not talking politely in India, when they go to a country where talking politely is a mandatory requirement, they become very polite and, put sir and madam before and after every statement. And of course, you will no denial of the fact that the doctor-patient ratio and the rush in our OPDs, etc., is there. But then at least we can prioritize on certain patients and do much better. And in a time of distraction, I think a few words of kindness can make a huge impact, and that compassion is something which is needed. Because ultimately, we when we do these trainings, we ask them, ki, if your mother was the patient, or if your child was the patient, and you or someone else was treating them, will you be happy with the way you treated them? Would you say, ki, oh, they don't have time for your mother and your child, and therefore seeing them in 2 minutes and not talking to them about a lot of stuff is fine? And if it is not fine for you or your family members, then naturally it is not fine for other people also. Because see, as a doctor, you may be seeing 100 patients in a day, but that patient is only seeing one doctor. And those 5 minutes, and for that 5 minutes of interaction with you, they've spent hours and hours coming to the hospital, waiting in the OPD queue, going back, taking medicines, etc. And those 5 minutes are like very important. So you just being knowing of that fact and being considerate and compassionate, a little courtesy, a little compassion, kindness never hurts anyone. It takes time, and time is something that we need to give, and we need to devise systems for doing it. But then that's the mool mantra basically, for all kinds of conversation. Because see, you may be trained to treat a queer trans patient, but then tomorrow you get an intersex patient, and we didn't talk about intersex patient. We'll be like, oh, now how do I talk? And therefore, as medicos, we need to have the humility to learn from our patients. And a lot of doctors learn from trans patients about transness, or from intersex patients or patients who have rare diseases. They sometimes know more than many of us, about their disease. So we should have the humility to ask them, Ki, how should I treat you? How should I talk to you? What will make you feel better? What is it that you don't like when someone tells you? Or what is it that makes you feel comfortable? How can I make you feel more comfortable? Do you have any question? Those certain things and questions can open a lot of doors and make the doctor-patient relationship very, very, beautiful and strong.
Thank you so much, ma'am. I love the answer.
Ma'am, we have few more questions in our chat. I will read them out. First question we have from Nitya. Nitya mentioned, for what you are doing. Thank you for existing and speaking up, ma'am. More power to you. As someone who is a queer doctor myself, are there any support group or network for queer doctors or allies?
I'm also reading the other questions so that maybe in view of time we can club all of them and answer together. So there's another question by CK which says, what do you see as the next most likely milestone our country will probably achieve in our journey about equality, legality wise, and society wise? And the last one by Vipassana, that in clinical settings, how do you practically navigate documentation when a patient's gender identity or pronouns don't align with what's on their official records, and what's the best way for students and interns to learn that respectfully. So, answering these questions together, one is, yes, there are support groups available. Especially, I'm someone who is very fond of WhatsApp groups, networks, etc., because these are, our support systems. So I'll be dropping my phone number, and anyone who wants to be added to the groups. We have groups where there are queer people who are doctors, and there are also groups where doctors and queer people come together, irrespective of whether you are a queer doctor or you're just an ally or want to learn. Um, so yes, they are there. And we do some workshops also about that. In terms of what I think is going to be the next thing in our journey, I frankly don't know the future. But if I was given a wish list, I would definitely want NMC to do more, and to maybe have a queer member in the National Medical Council, or for them to listen to more voices from queer, disabled people, so that these changes can happen. Because let's understand, now we are talking about 1 lakh medical students entering our system every year just in MBBS. And you have Ayush, you have nursing, you have a lot of other allied sciences, and the impact that they have is across the world. And therefore, if we can get a foundation right, I think a lot of things will be really helpful. And answering the question of Vipassana in terms of what to do when, suppose, someone comes whose legal document is different and their chosen name and chosen gender or pronouns are different. So we often follow a dual system in this, in which, since the medical records are also legal records, we record whatever is legally there in the documents on the medical records. But then, when we have conversation with the patient, so on the file we write, ki, okay, someone is known as, let's say, Vishal, but their chosen name is, let's say, Sonia. So while on the paper and on the medical records it is written Vishal, I, in my personal interaction, is going to refer to her as Sonia because that is her chosen name. And I'm going to use the she pronouns because that is what she wants. So you can do that, that have legal as well as the chosen side by side on the medical record. And in all the medical certificates, you use the legal aspects only.
Okay, ma'am, I think we have a few more questions coming in. I think if it is okay, do you want to take the questions, or maybe I can take these questions and I can send it over via mail and then get back to people who are asking the
I think
question?
I'll quickly answer them.
Sure, sure.
It's really nice that people are asking questions even after we have short the time. So the question by Pia, which says that a proud moment you'd like to share in relation to the work which has been done. And there are a few. One is, of course, the competencies that were added in the National Medical Commission. The law which says now ki, convergent therapy is banned, and it should not be practiced, and it will be considered a professional misconduct. Or for that matter, the queer people who are there in the trans people. And when I started, I was alone, and now I have at least 25 people and a lot more nurses and other people. And these are, some of the moments of joy, and which really keeps me motivated to work more. And answering the last question by Archie, when we talk about intersex, oh God, that's a very different topic altogether. And I think we'll need another webinar to talk about, the medical aspects of intersex, the legal aspects of intersex, and also the social aspects. In fact, that's a topic which is highly contested. And I, for example, complained to the Delhi Commission for Protection of Child Rights, saying that these surgeries on intersex children, which are done just to convert them into boys, should not be done when they are not medically necessary, because that is like genital mutilation, actually, which is happening. Let the child grow and then decide what body they want if they are a healthy, normal child, right? But then we have certain pediatric surgeons who, contested and said that our society is not ready for intersex children. And Yeah, like that is something, which really shocked me, that for the sake of the society, you would want to put a baby under surgery, which is actually going to harm them and not benefit them, and also to satisfy the parents' need, because they can't disclose that they have an intersex child and they want to raise the child only as a boy or a girl. So yes, I mean, that's something that needs to be discussed more, and maybe some other day, some other webinar.
We can make arrangements for that, ma'am.
Yeah, thanks.
Wherever so free. Uh, Anybody else, if you all don't have any question, Gia, do you want to add something?
Yeah. So, ma'am, I read one of your researches, one of your project basically about the transformative medical education in India, which was which you are a collaborator in, and I love the competencies that you have put up. I will be sharing ma'am's project in the group itself, and you can read the project that yourself, and maybe even though NMC doesn't have the curriculum, we can take a step forwards and start acting on take a step forward and start practicing and be more inclusive in healthcare practices.
Thank you.
Okay. Thank you, Gia, for adding that. And yeah, please share it in the group so that everyone has access to it. And as we don't have any more question, I would like to take this opportunity to thank ma'am on behalf of MSAI, to take out time from your busy schedule to be with us for this webinar. And your insights were not only informative, but also, very inspiring for a lot of us present here. And the way you spoke about your journey, and that was really motivating, because we really don't have people who are speaking about their journeys. So that's very inspiring. And uh, these things do, keep reminding us of the purpose and power of compassion, inclusivity, and, patient-centric care that we as medical students get into medicine for. So thank you so much, and we are so grateful for you to for being here, and staying here with us even after the time has passed, like half an hour over the time that we have
No
decided.
issues.
So thank you so much, ma'am, and it was really nice having you. Uh, Maybe we can arrange another webinar
Sure.
to
Sure,
decide
sure.
to have more talks about
Yeah.
intersex people. Thank you so much, ma'am.
Thanks, Partho. It was my pleasure, and thank you, the entire team, and especially the participants, for being there and for all the questions that you asked.
Ma'am, before you leave, we would like to take a picture. So if
Sure.
y'all are comfortable with putting your cameras on, please put your cameras on so that we can have a group picture. And as y'all are putting your cameras on, I'd also take this moment to tell that the post-webinar post-evaluation form for the webinar has been shared in the chat box. Please fill it up before you leave the meeting. It won't be shared again in the group or in your meeting. Okay. So I have 2 pages I need to take picture of. So keep smiling for a longer time. 1, 2, 3. Okay, page 1 done. 1, 2, 3. Yeah, I think that would be all. Thank you, ma'am, so much.
Maybe we can have one more photo with the Scora hearts if everybody is comfortable.
Yeah, sure. Ma'am, yeah, ma'am. Okay, on 1, 2, 3. One, two, three. Thank you so much, everyone. Thank you so much, ma'am. It was really great having you with us today.
Thank you, and see you again, hopefully.
Yes, ma'am. There is.
Okay. Yeah. Thanks. Bye.
Leah, are you there? Can you stop the live stream? Stop the live stream.